Hey, and welcome back to the Sequence Podcast. I'm your host, Dr. Spencer Nadolsky, and I got my lovely guest co-host, Dr. Danielle Don Diego, with me. And today we're going to be talking about hyper and hypo responders to GLP-1 medicines. And we could talk about any other medicine, but it tends to be these newer medicines are so powerful. It's always surprising to see how people respond to them. And when you look at say semaglutide, the STEP trials, the average is somewhere around 15% total body weight loss. And then they, it's interesting what they do in these studies. They break it down into how many people lost 5% of their weight, how many people lost 10%, how many people lost 15, and even up to 20%. And they did this also with the SURMOUNT trial, which was tirzepatide as well. So, but what's interesting is I wanted to bring Dr. Danielle on here. She's got a lot of patients, and as well as I do on Sequence, and we see the full spectrum of hyper and hypo responders. And you were telling me about someone on just the lowest dose of tirzepatide, just didn't even have to budge. And I've seen this as well. While we also have patients who titrated up, it takes multiple months to get up to the highest doses of whether you're doing semaglutide with Wegovy or whatever. It takes months to get up to the highest dose. And then we have patients who it's like, oh geez, these other patients barely touched the drug, even basically pulled the drug out of the box and barely sniffed it, and we're losing tons of weight. And then we have some people who just crank it up to the highest dose and barely budge. So I want to talk about this because we get a lot of questions about how much weight should I be losing? What have you seen? Like, you don't have to say how many patients. You've had a lot of patients, and you've seen the spectrum. What are kind of some of the things? We'll start off there.
Yeah. I would say majority of people follow within the expected parameters of expected weight loss. I have seen both extremes, however. For a hyper responder, like you said, I have had patients lose, I hesitate to say how many pounds because I like to look at the percent body weight more, but like 50, 60 pounds and never increased their dosage beyond the lowest dosage of a GLP-1.
Yeah.
They just responded fantastically well. I have not been able to figure out like who it is.
Yeah.
It's not somebody that like needs to lose more weight than somebody else. Like I haven't noticed a correlation there with like how much. I've gotten that question from patients. Like if I have more weight to lose, will I respond faster or slower? I haven't seen that to be the case. But I've had patients, some respond really, really well in a lower dose. And then I've had some patients where I get all the way up to the highest dose and maybe lose a couple pounds. And I know it's like super discouraging because
it is,
this medicine has been a godsend for so many people, GLP-1s in general, but there are just some people that their body is not taking to it.
Yeah, it's interesting. So, I don't think there's any formal definition of hypo and hyper response. We're just kind of doing this off the cuff, but I would say that a hypo response to me would be getting up to the highest dose of whatever you're doing, whether it's Wegovy or whatever, and losing fewer than 5%. So the reason we use percentages is because it's all relative. And you see this a lot with like spouses who are like, why is my, husband basically cuts out a few French fries out of their diet and they lose like a ton of weight. And
statement.
So just to make sure we keep everything relative, it's better to use percent of body weight. So for example, someone who's 200 pounds who loses 20 pounds, that's 10% of their weight, versus someone who's 300 pounds losing 30 pounds. That would be 10% of the weight. So that would be the same relative weight loss. Someone who's 400 pounds losing 40 pounds. So first off, you got to look at your relative weight loss, because that's where I think a lot of people see like, my friend lost 30 pounds in a month.
Yes.
And it's like, well, wait, where are you? Maybe you might be in that lower BMI where they have comorbidities. So like these drugs are approved if you have a 27 BMI and above, plus a comorbidity, which means like hypertension or high blood pressure, prediabetes or type 2 diabetes, that type of thing. So you may be in that lower weight range and you may lose 10 pounds. And that's still really good relative to your weight, whereas someone's 250 pounds, they lost 20 pounds, something like that. So
those 10 pounds could be in a few months.
Yeah.
We see some people who will lose 10 pounds or more in the first month, again, relative to where they started. And so someone might think, oh, I only have, 10 or 20 pounds to get into a normal BMI, and they'll get very discouraged. But
yeah.
It's very relative. So
Yes.
comparison mode is something very important to also bring up in this context.
What do they call is comparison is the thief of joy? Is that the right? Is that the right thing?
Mm-hmm.
It's true, and we get patients kind of I wouldn't say yelling. I don't know how they yell through a keyboard, but it seems like it because sometimes, and we have to go like, hey, no, you're doing amazing. Like, holy cow, you're actually, some patients are doing faster than the average of what we see in the trials. So our rule of thumb, and this is another thing we like to do our lessons about, you can look at the trials and over 72, so like for, it's about a year, but it's a little bit more than a year for both semaglutide and tirzepatide. And if you look, like semaglutide over a little bit more than a year, it's 15% on average. And you can do the math on how much percentage per week. But we have patients that, they lose about 1% of their weight per week in the beginning, and they're like, I'm going too slow. It's like, no, you're going plenty fast.
Yeah.
And so they think the expectations right there are important. And we do like to intervene sooner if we see people maybe not reaching some of those expectant goals. So that's why we refer to nutrition and whatever. But I would say a hypo responder, I think is not hitting the 5%. This is a true hypo responder. Some people may think it's 10% or half of what you'd expect, but I would say just 5%. If you don't hit 5% over the course of like in the first few months, 25 weeks, as you titrate up to the highest dose of whatever you're on, probably a hypo responder.
Yeah, that's if you get up to the highest dose, you've been on the highest dose for a full month or whatever, depending on which GLP-1 you're on, and you're not responding, I would give it a little bit more time. But and if we've done all the things like the dietitian and the exercise, all the other components as well. I think there's just a small percentage of people that, and I think that it also goes to show that, we talk about how, this helps people with their, I like to say hunger signals. And it goes to show that it's not like a binary thing. It's not like, oh, people have normal hunger signals and abnormal hunger signals. Like there's a spectrum, and there's going to be extremes on on that spectrum. So everyone's going to be a little bit different. So like you said, if someone's friend is responding really well, and then they're doing this together, maybe, it can be discouraging because their physiology might just be a little bit different.
That, and I think some people, when they get on the medicine, they just want to not eat anything at all. They want to shut off their hunger. We talked about this in the side effect podcast. If you hadn't listened to that one, you can go ahead and listen to that one. But they like go in it not wanting to eat anything.
Yeah.
And so then of course they're going to lose a lot of weight. And they just want the medicine to just make them not eat. It's like, no, we want it to normalize appetite. Yeah, please don't. Yeah, please don't do that. If you're doing that, you're probably listening. People are like, oh gosh, I think I might have done that. So that, and different people respond. The GLP-1s, they hit these receptors. There's GLP-1 receptors in the brain. And it's really interesting. Why would one GLP-1 agonist work better than another one? Some of it's how long it takes to degrade in the body, so half-life, how long it lasts in the body. So liraglutide, which is Saxenda, the brand Saxenda. For type 2 diabetes, it's called Victoza, but Saxenda is a little bit higher dose. That one's a once daily injection, not nearly as long of a half-life as its younger and cooler brother, kind of similar to how I am with my brother, the younger, cooler brother, the bigger one. He's not even on this podcast right now. He's listening. He's an endocrinologist. If any people might be listening, but it's semaglutide lasts longer. But there's also some thought of maybe the affinity to how well it attaches to these receptors. But these receptors are in the brain, and some people think maybe some of these cross the blood-brain barrier. We have this special barrier in our brain that allows some things to get through and some things not. Obviously, we want to protect our brain. So maybe these things are getting through and hitting the receptors differently in different people. I think there's probably, here's what I think too. So people are always like, what are we supposed to do we have these clinician calls every couple of weeks, and we do troubleshooting and, you know, what's everybody seeing, any side effects, and how well people are going. And one of the questions is, what are we supposed to do with these patients that are hypo responders? They have a 40 or 50 BMI, and they've lost, you know, 3% of their body weight. And I've seen it. I've seen it. Yeah. What's your line of thinking right now? And I'll explain what I think mine is.
As far as what to do?
Yeah, what to do.
You know, sometimes I will, you know, of course, depending on insurance coverage and cost, but I will try to switch them to another GLP-1. You know, I have to say I haven't done this so much in a telemedicine practice, but there have been times where I have done 2 different medications for patients in person, maybe for a short period of time, or just to see if we can get some sort of response. But, you know, I think if all else fails, bariatric surgery is still an option. I know we love to be as non-invasive as possible, but yeah. I think that there are just some people where that is going to be a real option for them. You know, and there's newer medications coming down the pipeline in the next few years. And I'm very hopeful that we're just going to have more and more options here for people. And, yeah.
Yeah, no, I think that's the right, I think that's the right way to go about it. Bariatric surgery. So these medicines, tirzepatide specifically gets up to 21% weight loss, semaglutide 15 or so % weight loss. Bariatric surgery is more in that 30% average. Again, there's hypo responders to that too. I've seen it.
There are.
You've seen it. It's kind of like, oh gosh. And we do have patients who do that and then come to see us for medicine. They actually work pretty well together.
Yeah.
Should probably do a whole podcast on that. But yeah, so if they're getting to only, you know, less than 5% and they have a lot of weight to lose, I wouldn't say, like, to me, if it's somebody in that lower BMI range, somewhere around 30, I would say, you know, and they don't have comorbidities, they're metabolically healthy. It's kind of like, hey, let's get you off the medicine. Maybe we could try another GLP-1 agonist. We talked about this before. We can't do phentermine or Qsymia, which has phentermine in it, because it's a controlled substance. That's an option. A lot of these patients have already tried that in the past, and they had side effects, anxiety, increased heart rate, that type of thing. So it is an option to either add that on or switch. My feeling, though, is these expensive drugs, if they're getting a hypo response, I don't know if we should add anything on. We should probably just take them off. You know, I don't know, because it's probably not cost effective. But then bariatric surgery, it's having that conversation. Some people, they don't want to hear that because it's, I don't want to get surgery. I want to do this on my own. But it's like, well, we can have the discussion, shared decision-making process. I think, you know, the other thing is, just from academic purposes, we have these genetic tests now that you can do. And I'm interested in why is this person having a hypo response? And you talk to them, sometimes they'll say, like, I don't know, I feel like my appetite's better and I'm eating, you know, fewer calories, eating less. But in general, that's how these medicines work. They're not fat melters. They don't boost metabolism. There is some thought that maybe there's some benefit for like non-exercise activity, thermogenesis, some of these other metabolic parameters, but mostly through appetite regulation. So I'd be interested. My feeling is that there has to be a genetic component there.
Yeah. The other question, kind of, you know, we don't really have an answer to, but when I do have someone who's a hypo responder, so often they're really just maintaining. They're not gaining.
Yeah,
you know,
that's true.
I haven't really seen anyone go the opposite direction over an extended period of time. So, you know, depending on what was happening before, if they were in a consistent gain and then this medicine helped them to maintain, that's something I'm not sure of what the answer is. But I have noticed that if they're a hypo responder, as we're defining here, they certainly have not continued to gain weight. So
yeah, that's a positive thing. We do like to get the dietitians involved, because it's like, okay, if your appetite's being taken care of, but maybe it's not, then that's why we dive in like, hey, is it helping? And a lot of times I think it is. So then it's like, okay, what are you eating and that type of thing? And then obviously the exercise, we have our fitness components. And, we do, despite being obesity physicians, we do care about non-weight, non-scale victories and non-scale health parameters, such as what are your habits, what's your fitness, and that type of thing. So it's always important to do those. So yeah, that's kind of our approach with the hypo responders, and it is frustrating for those listening. What about these hyper responders? I think these are fascinating because, like, let's go with Wegovy, a 0.25 milligram dose. I bet you have patients that go, don't even start me on 0.25. I heard it doesn't work. I want to be jumped up to 0.5 or 1 milligram or whatever.
People, I all the time. Can I just start at a higher dose? Can I? Yep. Like they're excited, they're motivated. They're like, let's go. And I'm like, nope.
Yeah.
Definitely don't want you feeling sick. Again, I always say I'm not trying to make you lose weight because you feel sick.
Yeah.
So we have to be careful. We always start small. And also because of this exact reason as well, I've put some people on the smallest dose and they just take off. And so they're like, when are we moving up? And I'm like, we're not. You're doing great. More medicine isn't always the answer, as with treating any disease. We don't just put people on the highest dose of blood pressure medicine to try to get them down as fast as possible. You'd feel terrible. These people that are responding really well, again, I haven't quite figured out like who they are versus the hypo responders, but it's fun to see. I will say it's rewarding from a clinician perspective, and I know that the patients are really, really excited. It also, usually the people that are most excited about their weight loss are the ones that will end up putting it online, which is great. Like I love, celebrate your wins. But for everyone else that's either in the normal responding category or hypo responding category, that's where comparison can set in. So it's just important to say that there are people that do respond really, really well, and it doesn't mean that anyone else is doing anything wrong.
Yes. Very good point. Yeah, I think we see this with like any, marketing. They show the highlight film of like their testimonials, and there's actually a study that looked at all the different weight loss programs out there that post their before and afters, and then they showed the actual studies on those programs, and they're like, these people are in the 99th percentile for weight losers or whatever in that in their program. So like this is probably discouraging and showing a wrongful expectations, and so they should really put an asterisk. And a lot of times the result's not typical, but it's a tiny little thing. And it's like that's where it's nice to say this is the average. If you're doing better, great, and if you're doing a little bit below, that's why some of the stuff averages out. If you're doing, the hypo response, then that's where we say, hey, this isn't typical.
This is where data and science is so important, because if there's anything out there that's marketing purely on testimonials, it's always a red flag, because if that's what we did, oh my goodness, like, we obviously don't do that. We're physicians, and we're doing all of this based on data, but that's why I always, testimonials alone,
very careful.
Really the top percent of responders and marketing.
Yeah. So it's interesting. So this is the other thing. So the hypo responders are probably also the people posting. So the extremes are posting. That's why some people come in going, I heard this dose doesn't even work. I want to go to the next dose. It's like, no, it does work. It can work. And in fact, like you said, can be very dangerous if we start you at a higher dose. I've had some people not even tolerate the lowest dose. Which is really annoying, because Wegovy, obviously you can't split the dose down from 0.25 to 0.125. And so like you can actually, what's interesting, so this is off label. If patients have type 2 diabetes, they use Ozempic, but you can actually change the dose with the pen there, and it's not on the label, but you instead of doing one full click thing with the Wegovy pen that goes up to 0.25, and that's all it can inject. The Ozempic pens, interestingly, you can click, and actually you can actually very precisely get different doses all in between those. So just an aside, if anybody's listening going, oh, I have Ozempic and I don't tolerate it that well, I want to do an in-between dose. You can reach out to your clinician potentially and discuss that possibility. So here's the other problem. Wegovy specifically, they want the FDA and everything, it's labeled to go up to 2.4, and some insurances will not continue to cover at lower doses. I've seen this a few times, and it is ridiculous because, but this is how it was studied. So like I don't know, this has something to do with the FDA, but like let's say somebody is doing just amazing at like 1 or 1.7 milligrams, and maybe they tried the 2.4 and they can't tolerate it, and it doesn't matter. They're doing so great with it. There are some insurances that are like, no, you can't keep. You got to go up to the 2.4 where that's all we're going to give because that's the maintenance dose. It's like that doesn't make sense from a clinical standpoint. So if you're in that spot and you're one of our patients, or want to be one of our patients or whatever, you're listening to this, let us know and we'll have to figure that one out for you. But that's one of the unfortunate things. If you're one of these hyper responders and your insurance is being weird about it. Kind of interesting.
Yeah. And on that note, I've also seen, like, if I'm switching between GLP-1s, like let's say someone's not responding to something and we're going to go to another one and I want to kind of start them at a different dosage. That's when we can do that, right? Is if you've been on a GLP-1 for a minute and we want to switch, if you've been on a higher dose, we can sometimes, depending on what it is, we can sometimes, start you at a little bit higher dose. I have had some pharmacies come back and deny starting at a middle dose of a new medicine because they see, that's not correct. And also from a coverage standpoint, they will only cover like starting from scratch. It's not the most common, but I have seen that as well.
I have seen it. Yeah. It's like, you guys have your medical license. Okay. Well, I guess you can start practicing then. I don't know. It is frustrating for, physicians, clinicians everywhere when we're like fighting with insurances and whatever. But anything else about
for a day when most of these are covered for most insurances, because right now and I know a lot of people that are either our patients or working with another obesity physician, just trying to find one that is cost effective and then hope that you respond to that one, right? We're kind of like, our hands are a little bit tied right now because of cost and coverage. And it's because, like the newer ones like tirzepatide, it's not yet approved yet for obesity, but we know that these things work. But Wegovy, was on back order. There's all these other things out there, right? So we're hopeful for a day where we're not jumping through this many hoops. The longer these medicines have been out, but we're kind of like right in that this time where these things are coming out. People are finally aware that these medicines exist, and we're, just for patients out there, we're doing what we can. But when things are new in medicine with pharmaceutical companies, it's never easy.
It's not easy, but we're doing our best, and I do think these medicines will become more covered. That's probably the biggest complaint I see online. Some people are like, I had side effects. I'm like, well, we could help with that, but the coverage thing is probably the issue. Like, I can't afford $1,000 a month. I'm like, I don't blame you. I don't think anybody really
I'd love to switch a hypo responder to something else and say, hey, let's try another molecule. Maybe you'll respond better. And sometimes it's like that it's just not covered too. So. Not
covered, not yet. So, all right. Is there anything else? I think we covered pretty much the hypo and hyper response. The definition of hyper response. Then I would say, like, on a low dose, you're getting you get, instead of like 15% on the max dose of semaglutide or Wegovy, you're getting more like 20% on like 1 milligram type of thing. You could say like a hyper response, like on the lowest dose, you're losing at 1% or more per week, and you just keep going. That's a good definition. I mean, we could just make up our own definitions because I don't think anybody else has figured this out.
That's exactly what I would not increase somebody. So that's how I would also define that, as like 1% or more per week. I typically don't increase somebody. So then that would, yeah, that would mean they're hyper responding to the lowest dosage. So
yeah. So when are you losing? So we have these parameters we made. So I'm actually loosening it up a little bit because Dr. Danielle mentioned 1%. That's about the average we tend to see at max. But once some people go up to like 1.5% in that beginning, some of it's water weight. Once people start getting that 2% of weight loss per week, so that's someone that's 200 pounds, let's say, and they're losing 4 pounds a week. In the beginning, it's kind of, it can happen because of water weight. But if they just keep going at that, it's like, hey, maybe we need to go down in the dose. But if it's the original dose, it will usually plateau. But some people, let's say they're on 0.5, they go up to 0.5, even though they're losing at that pretty close to 1.5%, and then they're losing 2% of weight. That's where we'd go, hey, no, we should go back to 0.25. And the reason is we have to tell the patients, because they want to lose weight as fast as possible. Yeah. We tell them, look, there's a risk of losing muscle, there's a risk of losing bone, and there's also a risk of gallbladder disease, gallstones, which is one of the risks of the GLP-1 medicines. We talked about this a little bit in the side effect potential, but if you get gallstones, you're at risk of having a gallbladder attack, cholecystitis, inflammation of the gallbladder, and also the pancreas if the little gallstone gets in the wrong spot there. So when you lose weight quickly, there becomes a change in the mixture of your bile, and you can make these gallstones, and they can cause trouble. So if you lose weight too quickly, that can happen. So it's possible they think there's maybe something with the medicine that changes the function of the gallbladder enough that where this could also happen. So we don't want to increase that risk by causing too quickly of weight loss. So it's very important if your clinician says, hey, you're losing weight rapidly, we're going to have it at probably a stoppage around 1.5% on average per week over that month. And if you're losing weight that fast, and you still want to go up, like take a second and say, look, the weight's not going anywhere. This is a marathon, not a sprint, kind of cliche type of stuff. But please listen to your clinician. And we have the resources. We have lessons all about this and explaining it a little bit more into detail and what to do. And we also encourage lifting weights to make sure you don't lose your muscle and your bone and that type of thing. So all good points there.
Yeah, no, I totally agree. The other thing I've seen only literally a couple of people with gallstone issues from after losing a good bit of weight. Hair loss has also been something that I've seen. A lot of people say they start losing hair, and I think it's more related to nutrient deficiency. I meet with the dietitians, but I think that it's just too fast, too soon. Nobody wants to lose their hair. Nobody wants gallstones.
No, I don't want any of that.
So there are things we're looking for. So, just be patient. And, I practice a lot of yoga, and anyone who practices yoga out there, there's something they always say, keep your eyes on your own mat. Because you could look around the room and there's, people doing handstands and all these sorts of things, and you might just be like getting into a normal pose. And so, a good rule of thumb, just something to remember, keep your eyes on your own mat when you're looking at your own weight loss and your own progress, because the person next to you has a completely different body makeup and might be in a completely different place, even though you might be on the journey with a friend or a family member. So, try not to compare as best you can.
Yeah. Unless you want to do yoga with me, I'd be like the Tin Man meme where the Tin Man's trying to do yoga. I'd be like, this is some BS. I'm so stiff. That would be me. All right. Well, thanks for listening. Hopefully you got some good information about hypo response and hyper response, and check out our resources if you have access to our lessons. Thank you.
Thanks.